Integumentary findings. Given that mast cells often are programmed to site themselves at the environmental interfaces, it is not surprising that a wide range of pathology is evident in the integument of patients with aberrant mast cell activation. Permanent or semi-permanent cutaneous lesions include xerosis, fragility, telangiectasias, including telangiectasia macularis eruptive perstans, and macular or maculopapular freckles. An unpredictable, unprovoked, diffusely migratory, patchy, lightly to moderately erythematous macular rash is the most common dermatologic complaint. Warts are not uncommon, and problems with spontaneous development of folliculitis and or small ulcerations. Sores, ranging from as small as 1 to 2 millimeters to as large as 2 to 4 centimeters, and often attributed to diabetes or vascular disease, given the lack of any other apparent explanation, are not uncommon, and often are long in healing, sometimes leaving scars, and thus raising the possibility of mast cell activation disorders underlying idiopathic sclerosing diseases. As noted previously, pruritus, sometimes localized but more commonly in an unpredictable, unprovoked, diffusely migratory pattern, is a common complaint. Flushing and angioedema, usually episodic but sometimes chronic, are common issues too. Idiopathically painful, sensitive skin is occasionally seen, usually affecting a region of the body more so than one small site or the entire body. Proper mast cell function is critical to wound healing, and thus it is not surprising that wounds in mast cell activation syndrome patients often heal poorly, taking a concerningly long period of time to close, not uncommonly becoming secondarily infected, and often leaving a more pronounced scar than would be ordinarily expected. Another very common dermatologic finding in mast cell activation syndrome patients is dermatographism. Sometimes simple removal of clothing makes it apparent, but integrating a simple, light scratch test into the physician's standard physical exam is an easy thing to do. The dermatographism of mast cell activation syndrome rarely is so vigorous as to manifest hives. Instead, usually only erythroderma is seen in the track of the scratch, arising within 1 to 30 seconds and often persisting in full splendor for 5, 10, or even 15 minutes or longer. Alopecia, usually not clinically apparent, is frequently reported in mast cell activation syndrome patients. Interestingly, increased levels of mast cell-specific prostaglandin D2 are found in alopecic scalps. Onychodystrophies of various sorts, too, are common complaints, especially in younger and overweight but not even necessarily obese mast cell activation syndrome patients. Striae are not uncommonly seen about the trunk, particularly the abdomen, anterior and posterior axillary regions, and even sometimes lower on the back, such as in the regions of the costovertebral angles. In the author's experience, striae sometimes resolve with effective mast cell activation syndrome therapy.